Good evening, everyone. Well done. That worked well. Thank you all for joining us tonight. This is the 2024 public lecture for the Australian-New Zealand Musculoskeletal Clinical Trials Network, or ANZMUSC for short. I'm Professor Anne Burke. For those of you who don't know me, I'm the Co-Director of Psychology in Central Adelaide Local Health Network and the lead for the South Australian Chronic Pain Statewide Clinical Network, and I'm really chuffed to be here to facilitate this session tonight. Now, before we begin, it's really important that we acknowledge the traditional owners of the lands on which we meet. SAHMRI is located on the traditional lands of the Kaurna people, and the SAHMRI community acknowledges and pays respect to the Kaurna people as the traditional custodians of the Adelaide region. We also acknowledge the deep feelings of attachment and the relationship that the Kaurna people share to their place. We pay our respects to the Kaurna ancestors and the living Kaurna people. I'm well aware that tonight we also have a lot of people watching us right now online and that will be accessing the recorded session later. And so I'd really like to extend those respects to the traditional owners on all of the lands on which our group is meeting. Together we stand for a future that works towards healing, connection and reconciliation. All right, so tonight is going to move along rather swiftly. Before we jump in, I really want to acknowledge our invited guests, Professor Maria Makrides, Executive Director of SAHMRI, Aria Bulkers, the representative for the Honourable Mark Butler, the Australian Minister for Health and Aged Care, representatives for the Allied Health and Human Performance Group at University of South Australia, the Arthritis Group at the Hospital Research Foundation, and members of the ANZMUSC and ANZBAC Consumer Advisory Group. So welcome and thank you all for being with us. And again, thank you to everyone that's here and everyone that's online joining us. From a housekeeping perspective, the toilets, should we need them, are out the door and to the left. The main auditorium door outside, I believe, is locked from about 6:45. So if you need to pop outside after that, you'll need someone to let you back in. Should we hear a fire alarm or a need to escape, we'll go out through the main doors and convene in the paved area out the front. When we finish tonight's proceedings, we'll be invited out to the main foyer to share some networking, some canapes and some drinks, and you'll have until about 8:20 or 8:30, and then we'll need to start moving people out because we have a hard cut-off here at 9 o'clock tonight, but that's plenty of time to meet and connect with the people around you. All right, so in just a few moments, I'm going to invite Professor Makrides up to open proceedings, and then we have got three fantastic presenters who are going to summarise the findings from their trials. Now, we love a good acronym. We've got the PEAK trial, we've got the methods trial, and we've got the WalkBack trial. And those findings are then going to be contextualised by our two commentators for tonight. We've got a consumer commentator and a clinical commentator, and then we'll be convening the panel at the front here for Q&A. We're really hoping that's going to be a lively, engaged conversation. There will be QR codes that pop up regularly across the night, and there's the first one. We're using the Slido app, so please do submit your questions right across the session, and then we can have the conversation with the panel during the Q&A session towards the end. All right, that's it from a housekeeping perspective for me. As I said, we're going to move along rather quickly tonight. I will introduce all of our panellists in due course over the evening. But now I'd like to invite Professor Maria Makrides to join us. Professor Makrides is a leading researcher in maternal and child health, specialising in nutritional science. She's the Executive Director of SAHMRI, an NHMRC Leadership Fellow, an elected Fellow of the Australian Academy of Science and the Australian Academy of Health and Medical Science, and she was awarded the South Australian Scientist of the Year in 2022. Maria's research is dedicated to enhancing the wellbeing of families and improving health policies related to maternal and infant nutrition. And she's here tonight to welcome us and open proceedings. Thanks, Maria.
Thank you, everybody, and welcome to SAHMRI. It's my wonderful privilege and honour to welcome you here today. I too acknowledge that we're on the lands of the Kaurna people and pay my respects to elders past, present and emerging. I also acknowledge that many of you have come from other lands and acknowledge the safe passage that we have all had to be here today together. Personally, I'm really excited to hear about the trials that your amazing network has been doing, and I congratulate the Australian New Zealand Musculoskeletal Clinical Trials Network for the wonderful work that they do and for the great trials that they've supported and the importance and recognising the importance of the evidence-based practice. And of course, an evening like this where the dissemination is incredibly important to engage and change policies and practices for the betterment of healthcare, but also in sustainable ways, and to be able to share that more widely. The thing that I've recently been thinking about is the issue of high-value healthcare, particularly in constrained environments as we have financially. But one of the things that I was recently challenged with is that high-value healthcare is also good for the planet. And one of the stats that I heard was that 60% of what we do is considered high-value care. 30% is probably wasteful and 10% is harmful. And from a planetary health or sustainability point of view, the way that we can actually better support as healthcare professionals sustainability for the betterment of our planet is to ensure that we have more and more high-value healthcare. So that's also obviously one of the things that we have been trying to achieve for the betterment of healthcare and also to contain costs, but it's also good for the planet. And that's probably one of the things that I think we need to be thinking about as we go forward, that high-value healthcare is good for people, it's good for hospitals, but it's also good for our planet. So congratulations. Looking forward to hearing about how we get these high-value healthcare interventions into practice and make sure that they're sustained and stay there. Thank you very much.
Thanks, Maria. That kind of poses the first question for the night. I was super excited to see health economics in some of these papers for exactly the reasons you're talking about, but maybe we need to start building in an eco footprint into our evaluation. All right, so now we're jumping straight into our trials. Our first trial for this evening is the methods trial. And here to talk to us about this trial tonight is Professor Flavia Cicuttini. She's a leader in the field of musculoskeletal diseases and currently serves as the head of the musculoskeletal unit at Monash University and the head of rheumatology at Alfred Hospital. She's an elected fellow of the Australian Academy of Health and Medical Sciences, and she ranks among the top researchers globally in her field. Flavia's research focuses on the prevention and treatment of musculoskeletal diseases, particularly osteoarthritis. I'm falling over my words already. Her work has been instrumental in advancing the understanding of osteoarthritis and facilitating new treatment trials in collaboration with biotech companies. Here's Flavia to talk about the methods trial.
Thank you very much for the opportunity to present our trial. I've got to do it very quickly, otherwise I'll be cut off, I got told. These are my disclosures. Thank you. So hand osteoarthritis is a big problem. 1 in 2 women and 1 in 4 men will have symptomatic hand osteoarthritis in their lifetime. It affects pain, it causes pain, affects function. It can be quite disfiguring and also quality of life. And in fact, the effect on quality of life is similar to rheumatoid arthritis, which we don't tend to appreciate. We don't have effective treatments. And some recent work has shown that, in fact, hand osteoarthritis is caused by joint inflammation. And you can see on this X-ray, this was an X-ray in 2009. This is the same joint in 2013. So if there's inflammation, it causes pain and joint damage, to the point that the pharmaceutical companies have tested most of the expensive biologic agents. They thought it was worth doing that. They don't work. And so we thought, well, what about methotrexate? It's got a broader action than the very specific. It's old, inexpensive, well-established safety record, and we're quite familiar with its use. So we did the methods trial where it was a multi-centre trial. We compared methotrexate at a standard dose, 20 milligrams once a week, to an inactive placebo in a trial of 97 people with hand osteoarthritis, 50 on methotrexate, 47 on control. We followed them for 6 months, and we found that methotrexate, we started to see an effect at 1 month, and that expanded at 3, and then the biggest effect was at 6 months, which follows what we know is the behaviour of methotrexate in rheumatoid and other conditions. It was safe and well tolerated, similar to what we find with other inflammatory diseases. So where to now? Well, we need to work out who's most likely to benefit. Our subgroup analysis suggests that it's women with that menopausal arthritis and tends to be earlier disease. How long should we treat? We had to cut our study short because of COVID. We'd intended to do a 2-year study, had to abort during COVID and restart and turn it into a symptom study. And is there going to be less joint damage? Most of the early data suggests that if you stop the inflammation, you'll also get improvement. We currently have an extension trial underway. So the question is, can it be used in clinical practice? Well, of course, the evidence is moderate effect. What we now have, so before we started our trial, 25 of 28 rheumatologists were already prescribing it off-label. So it was already being commonly used simply because there was no other treatment. So you can't say you should use methotrexate in hand OA, obviously, from these results, but it does give doctors and the patients an opportunity to have a discussion. Our study helps identify subject selection, and also what we found very clearly is that by 3 months, you're starting to see an effect. 6 months, you've got the effect. If it's not working by 6 months, you should just stop. So hand OA is a major cause of pain and disability, a major unmet need. We present high quality data from moderate effect of methotrexate in painful hand OA. And although a lot of unanswered questions remain, it does provide an option for discussion between patients and doctors. Thank you.
And that, my friends, is a masterclass in rapid and effective communication. You did very well. As we said, we've got lots of opportunity for questions later in the night. There's your QR code. Please do submit your questions through the Slido, and we will bring all the panel up to the stage in due course. All right, so next we're moving on to the PEAK trial, and Professor Rana Hinman is here to talk to us about this trial. Rana is a research physiotherapist and an NHMRC Investigator Fellow at the Centre for Health, Exercise and Sports Medicine at the University of Melbourne. Her research primarily focuses on clinical trials investigating non-drug, non-surgical treatment strategies for OA, emphasising exercise, rehabilitation and biomedical interventions. Rana's work has a focus on implementation science with a strong interest in increasing access to care through innovative approaches such as tele-rehabilitation and digital health strategies. As I said, Rana's here to talk to us tonight about the PEAK trial, so please make her welcome.
Thanks very much for the introduction and the opportunity to speak tonight. And I'd like to begin by acknowledging my co-authors and also the NHMRC who funded the trial. I'm going to talk firstly about why did we do the PEAK trial. And one of the reasons is because we know that 2.4 billion people globally suffer from a health condition that could benefit from rehabilitation. Yet we know accessing rehab can be really difficult. Telehealth can increase access to rehab, but patients and clinicians have concerns and worries about whether it's clinically effective, about whether it's cost effective, about the quality of care that's delivered via telehealth, and whether it's safe or not. And there's actually been very little research comparing video consultations with a physiotherapist head-to-head to in-person consultations to work out how safe and how effective telehealth is. And that's why we did the PEAK trial. What do we do? First, we recruited 15 physios across 27 clinics in both metropolitan and regional Victoria and Queensland. And then we recruited participants from the community around those physiotherapists. So we had 394 adults, 45 years and over, who had knee osteoarthritis, and participants had to have a certain level of pain and difficulty with physical function, similar to what we'd see with somebody with osteoarthritis seeking care. Once we recruited those patients, we randomly allocated them to one of two groups. One group had their consultations via video with a physiotherapist, and we used Zoom for that. The other group had their consultations in person in the physiotherapist treatment rooms. Both groups had 5 consults over 3 months, and you can see here on the slide that the treatment elements were identical across both groups. So the backbone of care there, which is best practice evidence-based care for OA, was osteoarthritis and pain education, a personalised strengthening exercise program, and a physical activity plan. And what we did was use surveys to follow up the patients over 9 months. So we measured at baseline, at 3 months, which was our primary time point, and 9 months. And you can see here on the slide that we measured a whole range of outcomes, including pain, physical function, which were our primary measures, quality of life, physical activity, self-efficacy. We had a number of measures related to the amount of time and distance it required to travel to consults, attendance, adherence, adverse events, satisfaction, and cost effectiveness. What did we find? You can see here on this graph, this is one of our primary outcomes, which is knee pain severity, and that scale, the higher the score, the worse the pain reported. You can see there that in both groups, the blue being video consult and yellow being in person, that there were quite large improvements in pain with intervention, and they were similar in both groups, both video consultations and in person. So we concluded on the basis of that analysis that the video consultations were non-inferior or not worse compared to in person. We saw similar results with our other primary outcome, which was physical function. And again, the statistical analysis there also showed that tele-rehab was not inferior. We found similar outcomes across the groups with most of our outcome measures. Adverse events were minor and similar across both groups. Interestingly, we found that video consultations were actually superior for some outcomes, and you can see those listed on the slide there. And when we considered the personal costs of travel and time in attending consultations, we found that video consults offered personal cost savings to individuals. So what does all this mean? It means that video consults are not worse than in-person care, and we can get similar improvements in symptoms with both of these models of care delivery. We showed that therapeutic relationships, patient satisfaction and safety are not compromised with telehealth. And this trial provides evidence to justify ongoing implementation of tele-rehab services as an option for patients, and also funding to support telehealth services. And it also suggests that telehealth training should be routine for physios, because at this many entry to practice curricula don't train clinicians, particularly allied health clinicians, in how to deliver telehealth care. If anyone wants further information, I'll direct you to the publication. Thank you.
That was fantastic. Thank you. I noticed the timing started before the pandemic, but there's nothing like a pandemic to push on telehealth research, is there? All right, so now for our third and final study for tonight, the WalkBack trial. And Professor Mark Hancock is here to talk to us about WalkBack. He's a leading expert in physiotherapy and currently serves in the Faculty of Medicine and Health Science at Macquarie University. His research focuses primarily on the diagnosis and management of back pain and has been supported by more than $11 million in grant funding. Mark's also an experienced clinician, having worked for more than 20 years as a musculoskeletal physiotherapist in the primary care setting, and he now brings that clinical lens to inform the work that he does in the academic setting. As I said, Mark's here to talk to us tonight about the WalkBack trial. Please make him feel welcome.
Thank you and welcome everybody. Let's go forwards. I'd just like to start by acknowledging the fantastic team that completed this trial, but particularly Tash Bakovi, who did an amazing job leading this during her PhD and is here tonight. So why did we do this trial? In the audience tonight, almost all of you will have experienced back pain at some point in your life. And for many of you, you will all have had different experiences of your back pain, but for many of you, you will have experienced this recurrent pattern of pain where you've had an episode and then you've had periods where you don't have pain or you have very little pain. We have really strong evidence that most episodes of back pain actually do settle quickly. And we equally have really strong evidence that most people have multiple recurrences. So for example, in the WalkBack study, on average, participants had 30 episodes before they entered the study. So clearly recurrence of back pain is a huge problem. But when you look at clinical practice and research, I'd argue that it's largely ignored. We focus on treating episodes and we forget about prevention. So there's been very little research that's actually looked at prevention of back pain. And what has been done has suggested that exercise and education together can help reduce recurrences. But these interventions are not very accessible for most people. They involve lots of sessions of turning up to a clinic, they're supervised, etc., and somewhat expensive. So what about walking? Well, walking is the most easily accessible exercise for most people. It's the most common, but nobody's actually looked at whether walking is able to prevent future back pain, despite knowing that it's helpful for other conditions. So what did we do? We recruited 700 adults and we randomized them into a walking and education program or a minimal intervention, no intervention control group. In terms of the intervention, the intervention involved 6 sessions with a physiotherapist, but ultimately the patients did the walking on their own. In terms of the intervention elements, in 3 of the sessions were used for the patients and the physio to meet together and come up with an individualised progressive walking program. And then there were 3 just quick catch-ups by phone, just to make sure that things were going well and help people overcome any barriers. In terms of the education component, it was really focusing on a modern understanding of pain, trying to reassure patients that pain didn't really mean damage most of the time, and also trying to give patients the skills to manage future recurrences if they occurred. In terms of our follow-ups, we followed people monthly for between 12 months and 3 years, depending on when they entered the trial. And our primary outcome was whether they had a recurrence that actually caused problems with daily life. And our secondary outcome was where they had back pain that meant they sought care. So what did we find? So on this slide, the y-axis represents the proportion of people experiencing a recurrence and the x-axis is time. So you can see that the blue line represents the intervention group. You can see that there was a 28% reduction in the risk of recurrences by being involved in this intervention. Oh, sorry, this is very touchy. And in terms of our secondary outcome, for care seeking, you can see that there was a somewhat larger effect and we reduced recurrences by 43%. As mentioned earlier today, we also found that this was cost effective. So clearly it's a fairly cheap intervention, but it was also associated with improvements in productivity and reduced time off work, which was great. So we just showed this slide because we got lots of really nice unsolicited feedback from participants during the study, and these were some of the things they told us. So when you look at these, you can see that beyond helping walking, people found lots of other benefits of being involved. So better mental health, better sleep, better engagement in life generally. So that was really nice. So what does all this mean? Well, to me, it's a really good news story. It means that we have this high value intervention that's widely accessible, that we know has lots of other benefits, but we now know can help prevent recurrences of back pain and prevent the need for care seeking. So we as a research team are working really hard to think, well, how do we make this more available? We'd like to, Tash is doing a lot of work looking at upskilling clinicians to deliver this well. But ultimately, as a society, what we need to do is to shift funding. We need to shift funding so that interventions like this, high quality interventions, are funded rather than some of the current low quality interventions. Thank you for your time.
Thank you once again to our 3 presenters tonight. They are our 3 clinical trials. We are going to move straight into now our commentary, and I'm going to invite Mr. Gary Cantwell, who's our consumer commentator for the evening, to come and join us. Gary's interest in musculoskeletal research is deeply personal, rooted in his own experiences with medical care over many years following sporting injuries and traffic accidents. Living with acquired cerebral palsy and permanent physical impairments, he's also been managing OA in both knees for the past 5 years. He's observed significant advances in treatment for musculoskeletal injuries that have been driven by research, and he himself has participated in several pain-related clinical trials. Since retiring, he's now actively volunteering in his local community, sharing his skills in strategic planning, advocacy and lived experience for the benefit of those around him. He knows our topics intimately. He's well placed to provide consumer commentary, and I invite Gary to the stage. Please make him feel welcome.
Thanks, Anne. So I'm very honoured here to be speaking today to you people. I'm just going to make a comment on each trial. I'm not going to pose any questions. If the comment poses a question, it's not meant to. We'll actually ask the questions later. But my first statement is going to be, I know they're summaries of your trial, but I couldn't see where there was any consumer involvement other than the patients. So I'm a consumer, so that was the first thing that piqued my interest. For the methods trial, it was originally designed for 2 years. You mentioned that, so I can see that. And it was reduced to 6 months, COVID. I understand the whole thing, but and you're doing a further study, you're doing an extension study now, I noted that today, but I see it as a missed chance by not doing the full 2 years with respect to the swelling and longer term effects of the drug. That was my comment. For the telehealth versus in-person consultations, I love the idea. I see a physio every other week, every second week. And the ability to be able to just have a telehealth conversation that goes for a few minutes and checking in that I'm doing everything right, or I've got a question to ask. I like that idea. That's all I've got to say about that one. But I'd like to probably, how would it translate into general practice from your study? And for the WalkBack, the intervention group had a higher incidence of lower limb injuries. It would have been good to see what those injuries were, because the treatment of those injuries, I'm wondering if that cost should have been shown as a part of the study. I mean, there's clearly evidence that there's a lower cost care in the intervention group, but if I think there was 100 so incidences of low limb injury, it would have been interesting to see what the cost of that would have been as well. Okay, thank you. Thank you.
Thanks, Gary. They were great questions, and I know you have specific questions for our panel when we get up on the stage, so we'll come back to those. But for now, we're going to move on to Dr. Sam Whittle to provide our clinician commentary for this evening. Sam is President of the Australian Rheumatology Association, a Senior Consultant Rheumatologist at the Queen Elizabeth Hospital here in Adelaide, a Senior Lecturer at the University of Adelaide, and an Adjunct Senior Research Fellow at Monash Uni. His main clinical interests are fibromyalgia and chronic pain, and his research focuses on epidemiology, evidence synthesis, and clinical guidelines. He played a key role in establishing the ANZMUSC network and is a member of its executive committee. Sam's also well versed in our topics for tonight, and he's well placed to provide our clinician commentary. So please make him feel welcome.
Thanks, Anne. Hi, everyone. It's a real pleasure to be here tonight and to see such a big audience gathered here. So I've got, of course, the most challenging job out of everyone, which is to try to interpret what all of this means. So why is this exciting to have all of these trials presented to you? Well, firstly, they're a big deal, right? These are great trials and they're published in a really important journal. So, you know, getting a publication in Lancet is a big deal. That's, for many researchers, that's a once in a career achievement. For some of us, it's 0 times in a career achievement. So it's a really big deal. So we're blessed to have this quality of research being done in Australia and presented to you tonight. Now, why are these topics important? Well, these are common problems. And so these trials are trying to answer important questions about common problems. I've been a rheumatologist for more than 20 years now, and I've seen a huge change in the way that we treat rheumatological conditions over my career. When I started, we couldn't really treat inflammatory types of arthritis like rheumatoid arthritis particularly well. And in the last 20 years, we've seen new ways of treatment and brand new drugs become available that have made some of those forms of arthritis extremely treatable. So over the course of my career, many times when I've met someone and looked at their hands and diagnosed them and said, well, I think you've got osteoarthritis, not rheumatoid arthritis. And I often get the question, is that the good one or the bad one? And my answer used to be, well, rheumatoid's the bad one and osteoarthritis, that's the not so bad one. And that's flipped now because I'm very confident that I can treat rheumatoid arthritis really well, but we're still struggling to know how to treat osteoarthritis of the hands and osteoarthritis of the knee and the hip. And we continue to struggle to know how to treat people with persistent pain of any type. And that's the type of patients that I see most often. So it's really great to have these trials that are starting to give us some insights into ways that we might be able to improve our treatment of these conditions. Now, there are some challenges still, right? So what do we do when we as clinicians read these new trials and how do we implement them into our practice? It's difficult. It's really hard to keep up with all this literature and then to work out what we should do with it. And amongst those challenges, well, how do we take these findings and apply them to the person in front of us? And it's interesting looking at these three trials that the average participant in these three trials is pretty similar, actually. Tended to be mostly women, tended to be middle-aged, tended to be relatively well-educated. And so my challenge as someone who works at the Queen Elizabeth Hospital and sees people who are sometimes different to that, how confident can I be that those findings will apply to people that I see, and in particular to the person in front of me? And so that's the big challenge for us as rheumatologists. And a lot of it comes down to looking at this evidence together with our patients and then making a decision together, a shared decision. But I think the big take-home message from all of these trials is around hope. So people who live with chronic painful conditions, like osteoarthritis, like back pain, can often find that their hope landscape starts to shrink, and it can be difficult to find hope amongst that. But the message that I'm often trying to give to my patients is there is hope. You know, chronic pain doesn't have to always be chronically painful. It doesn't have to always negatively affect your life. And we are likely to continue to find ways of treating it better and better with time. And when we see new trials like this produced that give us new insights into how we might treat these things, then that is a cause for further hope. And I think we can also be hopeful because we're seeing such high quality research being done here in Australia. It's fantastic. And what we hope for, from my perspective, is to see more and more research like this. So for all of you out there, if you want to see more research like this, go and speak to your local member, because musculoskeletal research is tragically underfunded in this country, and it's incredible what people are doing on a tiny amount of funding. So beat the drum and encourage your politicians to support more musculoskeletal research so that we can continue to have sessions just like this. Thanks.
All right, so as our panelists get settled, as I said, Gary had a question for each of our research team. So I'm going to pass him the microphone first to get underway. But just a reminder, people online won't be able to hear you without a mic.
Thank you. Thanks, Anne. So for the Makrides trial, what was the decision to reduce the time? Why was that?
So we had NHMRC funding and COVID hit. And when COVID hit, everybody terrified that the patients on methotrexate would be immunosuppressed and get bad infection and die. It sounds ridiculous now because it turned out to be okay. But But so the rheumatoid patients had a clinical reason for staying on it and they stayed on it. But for a trial like ours that was on handaway, we abruptly stopped. And then a few months later, when it became obvious that it wasn't going to hurt people, we just restarted. But NHMRC funding is really limited. And so realistically, we decided to either, rather than aborting the whole thing, turn it into symptom trial. And in fact, it was really interesting because the first signal that we had that there might be a benefit is we had people banging on the door asking us to restart. So, you know, it doesn't often happen in trials.
Thank you. So for the WalkBack trial, the COVID stay-at-home restrictions affected that as well. And it states in the paper that by the time we got to 12 months, the intervention group and the control group were almost taking the same time to walk and experiencing the same effects. So my assumption is, so there was less time to walk, probably because people were going back to work. And there was no ongoing support from the clinician that's stated in the paper. So I'm going to leave the find the time to walk aside because we're all working and we've got to find time to walk when we're told to do some exercise. But I see that ongoing support for a successful intervention of getting people out there to walk, how's that going to work? Because from what I do out in the public, without the support, people stop doing it.
It would have been on button up to the top.
Is that on? Beautiful. Thank you. Thanks heaps for the question. Yeah, look, we worked incredibly hard with the patients to do things that would help increase their compliance is the wrong word, but continuing to walk and to motivate them. So we use pedometers, we use diaries, all sorts of things. But it was very much around trying to give them the confidence to do it themselves. The result that you're touching on, a really interesting result that I didn't report. So the treatment group continued to walk actually and walk a lot. But we had this weird finding that the control group started walking more towards the end. We actually really honestly just don't understand that. So the intervention group did walk. When they rated their compliance, it dropped off a little bit between 3 months and 12 months, but not too much. So I think they rated themselves at about 6.5 out of 10. But I couldn't agree more. Ways to continue to support people is critical. We did have a 6-month follow-up for exactly that reason, to kind of try to help people. But ongoing support is really important for some people, for sure.
Thank you. Thank you. For the chronic knee pain and telehealth, I noted in the paper that there were no remote and very remote people in the trial. So I see it maybe as an opportunity to compare the intervention results with a sample of remote and very remote people. It'd be very interesting, take the travel side, it'd be very interesting to see what the effects would be on those people.
It's a good question, and there's a logistical reason why we couldn't recruit people from there, and it was because we didn't have physiotherapists who volunteered to be in the trial that were in remote or very remote areas. And obviously, if we recruited from a very remote area and then said to someone, you've been randomised to in-person care and you've now got to drive 3 hours. So that was that was the logistical challenge. So we could only recruit around where our physios were, and they were located in the regional areas and the metropolitan areas. But it's a good question. We don't know how these results would translate to people in those areas. There's no reason why they shouldn't, apart from the fact that Wi-Fi internet connectivity can be really problematic there, and that could potentially be an issue that could really impact that quality service via telehealth.
Thank you.
Great questions and great answers. fascinating, isn't it? Because we often say to people the reverse of driving 3 hours for an appointment, but coming into the city. So no one plans a pandemic, certainly not one the scale of COVID or one the scale of COVID in cities like Melbourne. It was an amazing feat for the research teams and many of the people in the room to do the same thing, to pivot and adjust and manage. So huge kudos for that. We've got a great question from the audience, which is fantastic findings. And this is a question for all of you. Do you have any tips about how we go about sort of speeding up translation, making sure that these findings get implemented into changing the way that care is delivered?
I'll go first and speak from the peak context. And I think COVID was obviously awful, but one of the good things that happened with COVID was we saw funding for telehealth services for the first time in this country, and many of that funding has remained in place from private health insurers and compensable bodies and the government. So one of those big barriers to implementation and translation has been overcome. One of the biggest barriers now is and our research has shown it, is actually the clinicians. Physios are changing habits of where people deliver care in person and are used to being a very hands-on profession. And so it's really, a lot of the work now, I think, is in shifting those perceptions with clinicians so that they are willing to offer services. And part of that, I think, comes with breaking down fears. People often think, well, telehealth, it's all or none. If we have telehealth, we're not going to have in-person care. And that's not true. It's an option. It's an option that should be there for patients. And it doesn't have to be black or white. It can be a hybrid or a blended approach. So that it might be that someone needs to have an in-person visit and then can have, as Gary alluded to, have some telehealth visits to save time from going in. So I think it's a bit about changing that culture amongst healthcare professionals to embrace new ways of doing things for the benefit of the patient.
So multiple strings to the bow as opposed to it being the bow. Flavia?
COVID was a total disaster, but the telehealth stuff was totally amazing. So, for example, at places like the Alfred, we were able to continue delivering care, which we would have had to stop. So that then changed everything, which included the clinical trials. So in Victoria, there was no way we could have done the method study if we didn't do it by telehealth. So we then pivoted to doing it by telehealth. And it was totally fantastic opportunity because we could do the screening with pathology or to the radiology. And we did it all through so Methods Extend is all telehealth, which means that we don't have the usual metro people who are, and also much more affluent who have the time. So we've been able to do a number of drug trials. So repurposing old drugs for OA. So we've just finished a metformin for knee-OA trial. All of that done completely virtually. And so I think that has been an opportunity.
Right.
And of course, if you take old drugs, if they work, and you can argue how much they work or not, the translation's quick because in fact, we got called by the ARA to say that there was real issues that lots of patients were wanting to discuss methotrexate.
Great, thank you.
Yeah, there's a similar theme that we were actually really lucky with COVID. For most people, it's a huge problem, but we started with clinicians just in Sydney and Brisbane, and then COVID happened. Our clinicians said, we love delivering this by telehealth. It's actually way better because it's very clear that the goal is on self-management and skill. So we recruited patients across the whole country. We recruited people as you're talking about, Gary, hundreds of kilometers from anywhere. So it's actually really exciting. And you know, we were just lucky. In terms of other aspects of translation, I mean, obviously, on one hand, we've got an incredibly simple intervention, but we're also passionate about it being delivered well. And we think that's important, you know, we put a lot of energy into actually delivering this well. It's not just going for a walk. So yeah, you know, on our website, we've got a website and it lists the clinicians, for example. So anybody in the country right now can contact them and get this intervention. And I would argue most clinicians can very quickly upskill, and that's something we would like to happen. We did train them in health coaching because we actually felt that was a critical element. So this wasn't driven by the therapist. This was the therapist and the patients together deciding what was going to work for them.
And this is something the audience is really curious about, that concept of training and whether that was easy or difficult and how your clinicians responded to it. Rana, I think it was your paper, apologies if that's wrong, but you had an online e-learning resource that sort of left some capability behind for people to pick up as well?
Yeah, we did. And we started our trial pre-COVID and trained our physios with an e-learning course, and then they did had some practice patients before they started in the trial. And then when COVID came, word got out that we had this e-learning course, and there was such a need for training that we took it off the university systems, which is where it was, and it's now available on a FutureLearn. It's called FutureLearn platform. People can access that for free, and it's for clinicians with the whole modularized training to deliver the interventions in our trial. And that's not just for over telehealth, but also in person. So that's one mechanism that we've used to help sort of upskill the workforce and help facilitate translation.
Thank you. So, I mean, with everything, investing the time into the training and the skill development is really important to make sure that the services are delivered effectively. Gary?
All I was going to say, if we're going to, and you did it was mentioned in the trials, if we're going to start using telehealth and new tools, the people have to be trained early, not later.
Yeah.
So that's going to reduce the cost. But with the methotrexate, it's used already for osteoarthritis. So how do you get the communication out so it's used quickly by all doctors that can use it?
Well, I think that it's because our results suggests that they're fairly preliminary. So there's a moderate effect.
Yeah.
And so I think the key is that I think a lot of people know about it. I mean, the rheumatologists were already trying it because there was nothing else. And I think our results show fairly clearly that, you know, give guidance, you know, if it works, it'll work by 6 months. Otherwise you stop, that it's well tolerated. So the message is sort of already out there simply because of the absolute desperation. In fact, most rheumatologists weren't calling it osteoarthritis. They were calling it seronegative inflammatory arthritis. But in fact, it was osteoarthritis.
Thank you.
So, Sam, we're talking your turf now in terms of guidelines and recommendations. As a clinician, further adaptations of these trials would you like to see for the studies to become more widely implemented?
Okay, that's a very challenging question, but I'll give it a go. So, I mean, I think for the methotrexate for osteoarthritis, I think, you know, the next study is going to be the really important one, right? So, I think we want to see how durable the effects are. We want to see if there's an impact on the actual structure and function of the hands over the longer term, because those are the things that are going to really convince me. You know, I think it's clearly important to see a potential effect on pain in hands, because the reason people come to see me with their osteoarthritic hands is because their hands are painful. But what we really want to prevent, as well as treating the pain, we want to be able to prevent the progressive change in the shape and the function of the hands. So I think that's going to be a really important question to answer. And if Flavia can demonstrate that, then we're going to really rush to take on this particular form of therapy for osteoarthritis. And you know, we have not had any medicines yet in osteoarthritis that actually change the course of the disease. So that's the holy grail in osteoarthritis, is a disease-modifying drug. So that's
No pressure, Flavia.
yeah. So please find us a disease-modifying drug for osteoarthritis.
It's quite interesting because the holy grail in osteoarthritis has been the disease-modifying agent, and there has been no treatment that affects both structure and pain. And in fact, recently there was some very nice work where a drug called spiriformin helped with knee OA. It was a new drug and it seems to slow progression. But of course, the Food and Drug Administration won't license it because it doesn't have an effect on pain. So it's a real challenge to find something that stops symptoms and progression.
So I've got two questions that I want to wrap up with. The first one is one I couldn't help but wonder as I was reading through the papers myself and thinking about the clinical work that we do. The energy and enthusiasm for telehealth was at one point when COVID first started. So Gary, I'd be interested in your view first and then the teams. Do we think people are still feeling the same way about it? Or do we think if we were to repeat some of these studies now, there's a difference?
Okay, I think telehealth's accepted by most of the population now. The very older of us, maybe they struggle a little bit. I work with lonely people and isolated people, and during COVID it was a challenge because we couldn't get out. So we implemented Zoom, and we ended up having meetings of 15 and 16 people who, and they were mostly probably over 70, over 80 years old, and they all started using Zoom. So it is possible with the right education that we can use tools like Zoom and whatever other tools.
Great, thank you. Do the teams have a perspective on that?
I can comment just briefly because ours was the only drug one, but it's been totally fantastic because we're able to get community-based people, not recruited from doctors and that. We've been recruiting through social media. We've probably done 4 trials, all drugs, all people coming from the community, and the ease and how and compliance and participation is much better. So there are, it's not suitable for all, but for, particularly repositioning old drugs and that, it's been fantastic.
And so from your perspective, people are voting with their feet because they're engaging.
Totally voting for their feet, with their feet. Yeah, it's the easiest we've ever had to recruit for clinical trials. And we've done one on low back pain, 2 knees, and a hand.
Nice. Thank you, Mark.
Yeah, look, just 2 quick comments. In terms of our intervention, I think it worked really well, but we gave patients choice. So we actually gave them the choice, and I think that's always what we should do. But I've been involved in some trials of really complex interventions for really complex back pain. And in those, our strong sense is that some face-to-face is definitely better. So I think you definitely have to think of the intervention and the clinical problem.
Thank you. Did you?
Yeah, I agree with the comments that have been made. We do all the clinical trials. All of our interventions are delivered via telehealth.
So then we've been asked kind of a big picture question, I guess, which is we've acknowledged the engagement that our consumers are connecting with this type of service delivery. It's not for everyone all of the time, absolutely, but it's getting some fantastic outcomes. It's really fostering much broader reach and connection, decreasing things like need to travel and difficulty accessing care. So you've also talked about training your teams broadly. What's happening at the university space or in the professional area? And I think this covers all disciplines, allied health, medical, nursing. Are you aware of what's happening to try and embed this early and upskill the workforce?
I can speak from the physiotherapy profession. A study one of our PhD students did, which was to interview educators at across a whole range of Australian universities, looking at telehealth curriculum in their physiotherapy degree program. And the findings from physio will be
probably translate across to other professions. But what we found is that it is really, really variable. During COVID, people, a lot of the universities did a bit more because they had to. They didn't have access to clinical placements. But it really depended on who was available in staff. It depended on what the clinical placements were. There doesn't seem to be any coordinated or dedicated approach. And it's not because educators don't think it's important. It's because curriculum is absolutely jam-packed. And it's not just telehealth that's trying to get jammed into there. There's 16 other conditions that we need to learn more about that. So we do need to do more about it, but trying to find space in university curriculums is a real problem.
Absolutely. No?
Yeah, just two thoughts. So I teach physio students, and last Friday I was marking assessments which were telehealth consults. So it's very much part of our curriculum. I think people see the importance. I think you were touching on training of clinicians though, and I'd like to pick that up because I think that's critical. Because a lot of these interventions, we're saying that the training of our clinicians was really important, and that's the barrier to implementation. And with some of the interventions I'm involved in, that's critical. And I'm seeing some really good work starting to particularly look at hybrid models, I guess, where some of the training is online and then some is face-to-face. And even in WalkBack, that's what we did. They did some preparation first, and then Tash met with them and walked through to make sure that she felt they were competent and did a little bit of extra training. And I think that's a good model.
A lot of the translation really becomes the tail wagging the dog. I mean, in some ways, Sam could comment on the clinical stuff, because really when COVID came, the government funded and then everybody rushed and it really kept us afloat. I find it very useful in the public system that we use a hybrid model because, so ours is all free. So it's sort of, and so it's really good because there are lots of patients just want to come, but we have a lot of patients who fail to attend and it's a free service. So we chase them up, which we can using telehealth. So in the public system, it has, we can afford because it's effectively free. I think how it then translates in private is very dependent on what the government decides to fund. Did you want to comment?
I think that's absolutely true. And I think we're really in the midst still of trying to reflect on what we learned during the pandemic, because it showed us through necessity that there are different ways of doing what we've always done and of delivering care. And while we have tended to want to regress back to what we were doing before, it has opened the door to other ways of delivering care. And then to see trials like this that show us that you can deliver care in this way and that it is effective, that helps us to continue having those conversations and to incorporate that, these possibilities into our thinking, as well as other novel ways of delivering care. Because what we want to do in the end is we want the care to be effective, but we also want it to be equitable. And that's really important, particularly for the patients that I care for. And we want it to be sustainable. So we want it to be sustainable for the healthcare system, but also for the planet. And I think that's where the initial discussion about the carbon footprint of our interventions is really important and will be an increasingly important component of the way that we evaluate interventions in the future.
So heads up, I'm going to start down Sam's end in just a sec because he's got the microphone, and I'm going to give each of you the opportunity to do one quick snippet take-home message that you'd like people to hear tonight. From my perspective as a clinician working in a really busy hospital service, it's really easy for us to get caught up in the reactivity of the demand at the front door and the seeing the people and desperately trying to do the right thing to provide good quality, sustainable care in the right way in what feels like an overwhelming environment at times. To have these types of research projects happen strategically, well thought out, with a really targeted approach to making sure that we can evaluate change, work out the right type of approach to improve care delivery is really important. And so I just want to congratulate all of our researchers and all of our researchers in the room that are dedicating lots and lots of time to doing that important work. So Sam, your take-home message.
Okay. High quality research that answers the big questions is really important and deserves to be funded.
Well done. That.
I would say telehealth's not a Band-Aid. It's not a one-size-fits-all. It's a safe and effective option that should be there for all patients to be able to choose when it suits them and if it suits their needs and their circumstances.
I'm going to give a plug to osteoarthritis. And I think it's a disease where we've sort of said osteoarthritis, but it's not one disease. That's why we're struggling with it. It's different diseases driven by different things. So a plug, methotrexate doesn't work particularly well for the knee. So I think targeting the specific joints and the patient characteristics, we're going to do much better. So targeting treatments to those who are most likely to respond.
Thank you. Gary or Mark?
Okay, thanks. So my comment would be that using our treatment as an example, it still needs to be individualized. So I think, people think walking is just walking, but all of these trials provide information that helps clinicians and patients in shared decision-making. And I think that's the key. It's when we just think of them as black and white answers that we have a problem.
Okay, thanks, Mike. So it's really good to, I understand the path to a drug trial and it's been used in the medical world. But the high value care is where I see the gap. And you've mentioned we need dollars to make it happen. But for both examples of the high value care, it's how's it going to get out there so it's used. Okay. So the WalkBack, I've got no doubt it works. And I read the trial. I like to walk, it helps my back. But how are you going to get the message out? And the only way it's going to do is money and some changes in the health system to make it happen.
So it's funding and it's sustained implementation, isn't it?
Yep.
Yeah. Please join me in thanking our panel for their generous contributions tonight. I think you can probably stay there because our wrap-up will be brief, I believe. But I'd like to invite Professor Rachelle Buchbinder to the stage. She's the chair of the ANZMUSC Clinical Trials Network, and she is going to close our session for tonight. Thanks, team.
Thank you. Thank you very much. Actually, before I begin, it's there. Is that the, pardon? Next slide. Yeah. Oh, so I'm going to move this slide. Yeah. Okay. So I've been asked before I do my final thank yous, if people could click on that link and provide any feedback for tonight, which will help us going forward to make these events hopefully even more beneficial for the audience and particularly our public. So I'll give you a minute to do that. No, I didn't. Oh my God. Do people need more time? I'm just seeing people still looking on the link. Give you 30 more seconds and then you can complete it while I'm talking. Okay, so while you're completing it, I'll just say one thing that wasn't on the list is that I'm incredibly proud of our ANZMUSC Clinical Trial Network. Since we started about a decade ago, the quality of our trials has improved. We're answering much more important questions, and more importantly, we're collaborating. So we're not competing, but we're working together to try and answer what is the most important questions that you, the patients and clinicians have to try and improve health for people with musculoskeletal conditions. So I just wanted to say that it's been remarkably gratifying for myself and probably the whole exec who've been on this journey for the last, can't remember how many years now, 10, 12 years. I'm really grateful to all the people that have helped to make that happen. So now gives me great pleasure to thank our sponsors, and you're all invited to have canapes and some wine tasting. And our two sponsors have our wine companies, so Samuel's Gorge and Burke Herring, who've been kind enough to donate the alcohol, because my Monash University credit card's not allowed to pay for alcohol. So that was a very clever way that our committee got around the problem. I'd also like to thank our supporters, and there are many organisations that have helped to get the message out so that we could bring our work to a much wider audience, including those who attended in person, and we also have quite a lot of people online as well. So I wanted to thank them. And I don't think on the slides, but I obviously want to thank all the speakers, the commentators, where is she? the person who kept everyone to time, and also the people who have behind the scenes who've set this evening up. And we've just got some little gifts for everybody. So I'll just thought, in case people run off, I wanted to do it publicly. So Flavia. Right, Rana. Right. What's it say? Gary. And Burke. Keith. Chris, Lynn. Tash. Where's Tash? Thank you. Erin, thank you. And last but not least, Sam, because we had to get vegan chocolate for him. Thank you. I hope you'll join us outside, and we've got the space till 8:20, 8:30. And the rest of you who are at the meeting, I look forward to welcoming you tomorrow at 9 o'clock sharp. So thank you, everybody. That's yours.